just as a show of hands, who's particularly interested in NF2 and who's particularly interested in schwannomatosis? So we haven't got a big schwannomatosis crew, but yeah, there is an interesting overlap which is relevant, which I'm going to talk a little bit about. But I'm just going to talk mainly about the clinical features, a little bit about the genetics, and a little bit about the imaging that we do in the conditions. So just a basic background to the genetics. We know that your genetic material is laid out on these chemical structures called chromosomes, and you have 46 chromosomes, and the NF2 gene is on one of these small ones, 22, and that's the vital gene in the formation of schwannomas. So the NF2 gene, sometimes people get the idea that why don't you just kill the gene? It's actually making the gene work properly that's the problem. So the problem in NF2 is the gene isn't working. So it's not killing the bad gene, it's making the bad gene good that we need to do. And that gene produces a protein that's usually called myelin, and that is a good protein that does good things, that keeps your cells normal and doesn't let them form into tumors. So the basic understanding about this is that all tumors are effectively genetically caused. Doesn't mean they're all inherited, but in order for a tumor to occur, genetic mutations have to occur in key genes. And for schwannomas, essentially, as far as we're aware, all of them have loss of the NF2 gene protein product. So that NF2 product isn't working properly. And that's directly involved in NF2 and indirectly involved in schwannomatosis. So the key understanding of this is understanding what a tumor suppressor is. And essentially, all our genes come in pairs, and if you inherit a faulty copy of NF2, or for that matter, LZTR1 or SMARTB1 for schwannomatosis, one of your copies is already faulty. So all you need to do is lose the other copy at any stage, usually by a process called deletion, and there is no functioning NF2 protein there. That is when you get a tumor. So you're not born with tumors, you have to at some stage lose the functioning copy of the gene in order for you to get a tumor. And for that to occur sporadically, and we have to remember that 95% of schwannomas occur as one-offs, you need to be unlucky enough to knock out both copies of the gene in the same cell. And that's a particularly unlikely event, and that's why only about 1 in 1,000 people develop schwannomas. So this is like the brakes on a car. The car is fine as long as one set of brakes is working. When you knock out both sets, there is no way of stopping that car. But that car probably still needs you to slam the accelerator pedal on for you to get a tumor. So simply losing NF2 alone probably is insufficient. So you need additional genetic events before that turns into a tumor. And probably the additional events decide how rapidly that tumor grows. These can occur by different mechanisms. This is far too short a talk to tell you about how that occurs, but just suffice it to say that the usual way the second copy is lost is by losing a large chunk of chromosome 22, which is very relevant in schwannomatosis. So what are schwannomas? They're benign tumors of the lining of the nerve. It's a bit like an electricity cable, and the Schwann cells are like the insulation around the wire. And they form into clumps when NF2 isn't working properly, and eventually into a tumor. And that's what the problem is. The vast, vast majority of these schwannomas are benign. Possibly 1 in 1,000 of them becomes malignant. So very, very unlikely. So these are the diagnostic criteria for NF2. The original NIH criteria from 1987 are in white, and the ones in green are the ones that I added in the Manchester criteria to allow you to get a diagnosis if you didn't have bilateral vestibular schwannomas, so bilateral tumors of the hearing and balance nerves, sometimes called acoustic neuromas in the past. And if you, with no family history, and more than 50% of people with NF2 have no family history, do not have bilateral vestibular schwannomas, then you don't meet the original criteria. And not everyone presents with bilateral vestibular schwannomas. About 15% of people have a significant gap between the two sides. And that particularly relates to a process called mosaicism, where the gene fault hasn't been inherited in the egg or sperm that makes you that first cell, but the gene fault occurs as you develop as an embryo, possibly as a cluster of cells. So the key tumor here is the vestibular schwannoma. Half of all schwannomas occur on these nerves. We have no idea why, but this nerve is particularly susceptible to the development of schwannomas. We know that around 1 in 1,000 people will develop a vestibular schwannoma in their lifetime. That means about 1 in 500 people will develop a symptomatic schwannoma of some sort in their lifetime. This gives you the distribution from our population study of 10 years. You can see the NF2-related schwannomas are much younger, vestibular schwannomas, and these are the sporadic ones. So they dwarf NF2 once you get past 30 years of age. But in the very young age groups, NF2 is actually more common than the sporadic schwannomas. And in terms of that, you can see here that there's no real difference in the incidence year by year in NF2, but they're getting more and more commonly found in the general population because of MRI. And the older people are having MRI scans and they're picking up tumors that may never have caused them any problems. So the incidence that we worked out, and this is going up all the time, there isn't a particular female predominance, which was once thought. It probably meant that women were more likely to come forward with symptoms than men. And it's probably going to be around 1 in 60 to 70,000 per year now. So probably in the future, more than 1 in 1,000 people is going to be diagnosed. So how common are the conditions we're talking about? Well, we've been able to map our really good epidemiology in the northwest of England with a cancer registry, a children's tumor registry, and a genetic registry. And we've been able to, therefore, identify the likely incidence and prevalence of these conditions. So incidence is the number of people born with a faulty gene, and prevalence is the number of people living in a population with a diagnosis of NF2. And these are the previous studies. You can see here NF1 far more common, around 1 in 2,500 to 1 in 4,000, than NF2, which is mainly from 2 studies, my own studies in the Northwest and 1 study in Finland. And what we did was map the dates of birth of people with NF2 onto the number of births in the general population in our region. And we were able then to actually come up with a really robust estimate. This is the only previous estimate of NF2 and schwannomatosis from Finland, based on a relatively small population. And they found NF2 and schwannomatosis to be as common as each other, at about 1 in 80 to 90,000. Now, a lot of people have taken that to mean that schwannomatosis is as common as NF2 with an incidence of 1 in 30 to 40,000, which is the incidence I published. I still don't believe it's as common as that, although it may be under-recognized in the general population. So this is what we get from mapping these on to the population: 1 in 2,700 for NF1, 1 in 33,000 for NF2, and 1 in 69,000 for schwannomatosis. And that is based on 899 living NF1 patients, 73 living NF2 patients, and 32 living schwannomatosis patients in our region. So the prevalence here is about 1 in 58,000 people and 1 in 125,000 people with schwannomatosis. And you can see here that 12 out of those 32, we've identified the underlying genetic fault in the genes concerned. So, vestibular schwannoma, the classical feature of NF2. In the past, it was thought that nearly all of the tumors occurred on the superior branch of the vestibular nerve. We now know that's not the case. It occurs equally on both branches. And often in NF2, it's like a bunch of grapes. It's not a single tumor. It's lots and lots of little tumorlets. That makes surgery more difficult. That makes radiation treatment more difficult. And that is why the results are poorer for hearing preservation, for facial nerve preservation in NF2 compared to the general population. So these tumors on MRI scans, you can see here, grow in this. So the white here is your brain. This is your brain stem. This is your cerebellum here. This is the cerebellopontine angle, and there's a great big space there that this lump can grow in. It can get to 1.5 inches, sometimes 2 inches in diameter before causing major hearing problems. But it can cause major hearing problems when it's tiny. Just, 1/10 of an inch sometimes is enough for it to actually start to cause hearing problems. So it's very, very variable. Ooh, something's ticking at me. But you can see here, these are the tumors enhancing on gadolinium enhancement. So meningioma is the second commonest tumor in NF2. It's predominantly cranial, but you do get them on the so these are on the surface of the brain, the meninges, and you can get multiple tumors. They can occur on the spine. Lifetime risk of having a meningioma probably approaches 75%, and it varies as to what type of genetic mutation you have. There is no actual female predominance in getting them, but if you get them, women get more of them, and that's because they're hormone responsive, particularly to the female hormone progesterone. You can get these schwannomas on all of the nerve roots where there are Schwann cells, so all of the nerve roots except 1 and 2. So here you are, these are optic meningiomas on 2. And this is 232 patients, and you can see here the fifth nerve, the trigeminal nerve, is the most common other nerve for them to go on. The seventh nerve, very common. We often see 9, 10, 11. The nerves for swallowing in particular can be affected. And this is a poor little lad who had trigeminal schwannomas, and this is both his schwannomas were involved. One had actually fixed his eye, so he wasn't able to move his eye because the tumor had come forward into the orbit. So you can get the schwannomas on the spinal nerve roots. These can cause pain, but not as much as they do in schwannomatosis. Typically in NF2, they cause loss of muscle function if they're in the neck, affecting the arms, or in the lower part of the spine, affecting the legs. So the difference between NF2 and schwannomatosis is when these are removed, you often, usually, lose muscle function if the nerve is sacrificed. Whereas in schwannomatosis, you can often take the schwannomas off the nerve and there is no loss of muscle function. So this suggests that the schwannomas in NF2 predominantly affect the motor nerve roots, supplying the muscles, and in schwannomatosis the sensory nerve roots because of the pain issue. So these, you can see here, this is your vertebrae going down your spine. This is the spinal canal. This bit here is your spinal cord, which stops at around L1, your lumbar vertebrae 1, and these are little, well, not so little tumors coming down the spine. This is outside the spinal canal, here, here, and here. And you can see, again, lots of dots of tumors at the bottom of the spine in the so-called cauda equina, the horse's hair that comes out of the bottom of the spine. So often you can remove tumors, and you're going to hear a talk by Michelle Calamarides later on with full symptomatic relief. But you can, unfortunately, in NF2, leave damage if it's not possible to preserve the nerves, and unless your name is Alan Belzberg, it's actually not common, as Jayshree's shaking her head, I think, to actually preserve the nerves when you're in the spine. So the other tumor that's actually coming into focus more is a tumor that occurs particularly in the cervical spine, in the neck, inside the spinal cord itself. Now, these are generally indolent. They look far worse than they are, but they can then suddenly cause loss of function. And the argument now is, in the past we've tended to leave them alone. Now we are more and more, particularly in those that are showing signs of increasing, when there begin to be any symptoms, thinking about surgery, or possibly you may hear other forms of treatment for ependymomas. Skin is affected. In my original study, I found the skin was affected in at least 70% of people. Now, these plaques in the skin, they're sort of raised, slightly more pigmented, often hairy, and these plaques here are schwannomas in the skin. You do not see this in schwannomatosis. This is an NF2 specific issue. So why we don't see it in schwannomatosis, I don't know, but you really do see it. It's a classical thing in NF2. And often, if you can't find the mutation in the blood, you can biopsy one of these little plaques and identify the mutation in one of those skin tumors without having to have major surgery. You also get these tumors on the peripheral nerves, and these are pretty identical to what you see in schwannomatosis, except they can get very large in NF2 without causing pain. It's unusual for them to get large in schwannomatosis without causing pain. So progression is rare, and certainly progression to malignancy is vanishingly rare in NF2. There really is no evidence that there is an increased risk of malignant change in a schwannoma in NF2. There is, unfortunately, for SMARCB1-related schwannomatosis. The only time when there's really likely to be an increase, and it's still small, is when you irradiate, when you treat the tumors with radiation. So this is the onset of symptoms. And you can see here going to 100% by around 55, 60 years of age. In adulthood, the predominant symptom is hearing loss and buzzing or ringing in the ears and balance problems. In childhood, it reverses around, and it's usually other symptoms that present in childhood, often related to a meningioma or a spinal schwannoma, or to muscle weakness in some of the nerves. Particularly facial weakness is a common presenting feature in childhood. And that's sort of reflected in nearly 500 UK patients here. You can see here meningiomas and spinal tumors do make up a reasonable number of the original presenting features in people. So this is using MRI in first-degree relatives, children of people with NF2. You can reverse that and say, well, how much has the risk gone down if the MRI scan is normal in your child? This assumes you start off at 50-50, which isn't actually the case, because many parents are mosaic for the mutation. So the risk of passing it on, if you're the first in the family to be affected, is often considerably less than 50-50. So there is a clear correlation between your genotype, the genetic mutation that you have in NF2, and how severely you're affected. And particular types of mutations called truncating mutations give you the worst pattern. Other mutations which just change a single amino acid in the protein called missense mutations give you the best prognosis. And that's sort of reflected in here, where you can see that a missense mutation, mean age at diagnosis is over 40 compared to 21 for a truncating mutation. So mosaicism is really common. We've already proven 185 people with NF2 have mosaicism. Often you can detect it at low levels in the blood, but often you have to go and find it in the tumor itself. And this means if you're the first to be affected in the family, and you're relatively older at presentation, you are much, much more likely to be mosaic. So if you present with bilateral vestibular schwannomas under 20, there's only around a 12% chance you're mosaic. Whereas if you present with bilateral vestibular schwannomas over 40, there's a 70% chance you're a mosaic, and a 93% chance you're a mosaic if you present with a unilateral tumor and other NF2 features. So the more sort of skewed you are, the less symmetrical your presentation as the first in the family to be affected, the more and more likely you are to be a mosaic with increasing age. And that has a big effect here. Even without mutation testing, we can say that the chances of passing on the gene have dropped very substantially. A lot of women worry about pregnancy. Pregnancy is not an issue for schwannomas. Schwannomas do not convincingly have hormones related to them, but the blood supply does increase in pregnancy, and it may cause an artificial increase in the size of tumors around pregnancy, which then shrink back down afterwards. So there is no convincing evidence that women need to be worried about vestibular schwannomas and pregnancy, although you do need to be worried if you have lots of meningiomas, and certainly you need to speak to your specialist if you're thinking about getting pregnant. So, schwannomatosis, have we gathered any schwannomatosis people here? So the diagnostic criteria from the start have been really to do with the absence of vestibular schwannomas, but the presence of predominantly painful schwannomas elsewhere. And there was always concern that there was overlap in this condition. And obviously, you've used vestibular schwannoma as an exclusion criteria, so no one actually looks at people with vestibular schwannomas for the genes, which is a problem because you've then created what we call an ascertainment bias. So the other thing is you can get schwannomas by chance, by sort of radiation exposure. This study in Israel, actually, no, it's not the Israel study, Schneider study showed that when they started to use radiation treatment for tonsillitis, believe it or not, in the 1930s, many people developed multiple meningiomas and schwannomas, almost certainly from the radiation exposure. And 4 of those patients actually fulfilled schwannomatosis criteria based on the fact that they'd been irradiated. So it's not always that you're going to meet schwannomatosis criteria because you've got schwannomatosis. So the diagnostic criteria is hinged around not having vestibular schwannomas, but that is becoming increasingly untenable, and we have to, in certain situations, screen people who get a unilateral vestibular schwannoma and other schwannomas for the LZTR1, the second gene. So most people present with painful tumors, but not always. The tumors are not in the skin, as I've said. They occur under the skin on the major nerve roots and in the spine. And you do get them, here are the spinal ones again, very similar to NF2. You do get them also on the cranial nerve roots. You can see here many of the people with proven schwannomatosis, again, the trigeminal nerve, the nerve for sensation to the face, being the most frequently affected. But can they get them on the 8th cranial nerve? This is a Norwegian family where we found several with cranial nerve tumors with a proven SMARTB1 mutation, and unfortunately one of these developed a malignant peripheral nerve sheath tumor. But in LZTR1 there is clear evidence that you get vestibular schwannomas. So 5 out of 50 people who had a unilateral vestibular schwannoma, 2 other schwannomas, had an LZTR1 mutation. And actually a germline LZTR1 mutation in all the cells was more common than an NF2 mutation in all the cells when you confined it to people with a unilateral schwannoma, 2 or more other schwannomas, and no other NF2 features. So clearly there is overlap. These are the cases you can see here. Getting their vestibular schwannomas after 30, so a clear cranial scan at 30, is not necessarily going to be reassuring that you do not have you do not have schwannomatosis if you have because you could get a vestibular schwannoma after that time. So in terms of the conclusions of all of this, we do have to think about the overlap a bit more. Mosaic NF2 can present as schwannomatosis, and LZTR1 schwannomatosis can present as NF2 with the unilateral vestibular schwannoma. So in terms of imaging, we now favor, as does Jayshree, doing whole body MRI on schwannomatosis patients. You don't necessarily need whole body MRI to pick up tumors like this. This, in fact, turned out to be an MPNST in a SMART-B1 patient. And this actually was high on a PET scan, higher than this one, but this one was benign. So PET is not necessarily a very helpful thing in deciding. And just to slightly go into Jayshree's territory, she's going to come next. This is treatment of spinal schwannomas with the drug avastin in NF2. And you can see here that this mass of tumors here shrunk on avastin. And this lad was in a wheelchair, he'd lost his bowel and bladder function, and he's now running around 5 years later on a low dose of avastin. So occasionally you get these almost miracle stories. This is another guy. You can see big tumors here that have all shrunk on avastin treatment, and he had huge, terrible amounts of pain, and he has again responded to that. And this can occur in schwannomatosis as well. This is a schwannomatosis patient who had a very big reduction in the size of her schwannomas. It doesn't work for everyone and needs to be done on a case-by-case basis, but there are potential indications for it. So overall conclusions, that NF2 and schwannomatosis are separate but very much linked conditions. The NF2 gene is inactivated in all schwannomas in schwannomatosis and in NF2. The mechanism by which you get there is just a bit different. And although NF2 is characterized by bilateral vestibular schwannomas, you can get vestibular schwannomas, particularly in LZTR1-related schwannomatosis. And NF2, I believe, is still commoner than schwannomatosis, which is a little bit different to the literature that you read, and avastin potentially is a drug that will work for both, and Jayshree has published a case report of this being effective as well. And I couldn't do all of this without an amazing team of people, a lot on the epidemiology side, a lot in our fantastic NF2 clinic that we have in Manchester. Thank you very much.